Welcome back to our plenary sessions. At this time, join me in welcoming Dr. Frida Lewis Hall, clinician, educator, researcher, and leader in biopharmaceuticals and life science industries.
Thank you for allowing me to join you at Healthy Churches 2030. It is my honor and a blessing to be with you on this journey. And I must say, I'm a little nervous as well. I was trying to think about how it was that I could convey meaningfully and helpfully such complex information to a knowledgeable and committed group such as yourself. And I asked myself, should we do this through a COVID lens since it is urgent and it's current and there's a need? Or should we do this in the context of long-standing health disparities in our community and think about it that way, since we're in for the long view with Healthy Churches 2030? Or should we think about this from a social determinants perspective and talk about some of the things that make our community healthy or unhealthy? Or should I just take a personal approach and talk about some of the things that have shaped me and my interest in medicine in general and health disparities specifically? And if you'll indulge me, what I'd like to do is a little bit of each. And I came to that conclusion because I believe that holistic well-being is, well, holistic. And if we're going to make meaningful, sustainable changes in our community as they relate to health, then we're going to need to look at different perspectives to devise our solutions. And that means we'll have to have different views. So let me start with my personal story, and I'll be brief. I became interested in being a doctor when I was 6 years old. I was inspired to do that by the care and the caring that was received by my uncle, who came to live with us when I was born. He was a paraplegic due to a polio infection when he was just 6 years old. And I have to say that as a young child, listening and watching and being a part of the care that he received in our house and out in the medical community was just mesmerizing. And that was from our family physician who took such good care of us, to the surgeon who fused his back so that he could stand straight on his crutches, to the healthcare team that took care of him in rehabilitation for nearly a year after the surgery, the brace makers, the occupational therapists, the physical therapists, all of these people caring for him. I was hooked. And I have to say, for a young girl of color in the 1960s, not from a medical family or a medical background, to decide this was pretty much a bold goal, but my family was all in. So in 1976, there I was at Howard University College of Medicine. That was my first exposure to health disparities and disparate care. Not at Howard, but through the history that I learned then about polio. I learned that in the mid-1920s, when my uncle was infected, and in the 30s, it was believed that Blacks were not infected by polio. And because of that, and because of segregated care, no care was provided to the African American community. And it wasn't until the now March of Dimes gave a grant to establish the Tuskegee Center for the Treatment of Infantile Paralysis that we had a center of care. Imagine, a decade and a half or more after the infection started to ravage the United States. The lesson I learned there was that we need high quality, culturally appropriate care for all that ails us. That was the first lesson that I learned, but it wasn't the last. The next summer, my mother died suddenly of a stroke. I knew nothing of strokes then. I was busy trying to get through anatomy and biochem, but finally learned more through talking to experts and through doing whatever reading I could. And what I found was that we really didn't know much. I didn't understand why my mother was so at risk and why she had to die. so young. We know more now. We know more about the risk of stroke, that there's a 50% increase in the risk of an African American having a stroke, and a 50% greater chance for them to die from it. And if you look at younger adults, 55, for example, the likelihood of dying from a stroke is 3 times what it is for a white American. My mother died just shy of her 52nd birthday. What I learned from that was how important it is to understand the risk factors. And by understanding the risk factors, which we now know more about, high cholesterol, hypertension, obesity, smoking, then we may have a chance at preventing this disease that's ravaging our community. Health literacy, health awareness, improving healthy behaviors. The next lesson came when I was given the privilege to take care of all the people that my mother had taken care of before she died. And that included my grandparents. They lived about 100 miles south from us in Richmond, Virginia. But I visited enough and talked to them enough that even though they were in good health, I started to notice my grandmother was becoming forgetful. She was misplacing things. She was mistaking a lot of things that she commonly knew all about. A few trips down the road and to healthcare providers, and ultimately she was diagnosed with Alzheimer's. I have to say it was one of the most devastating experiences to watch her decline over the years and to finally be taken by this devastating disease. As you can imagine, I did my best to learn as much as I could about Alzheimer's, and in particular, how this disease would affect African American women. There was very little to be said about that at this time. And even now, we don't know as much as we could or that we should to make the difference. Some of the studies suggest that between 14% and 100% greater risks of developing this disease exists for African Americans. We also understand that there may be a greater familial risk, and that some of the genetic risks and even some of the other risks, the environmental risks, may not be the same for African Americans for the development of Alzheimer's. What did I learn from that? I learned that we don't know enough. I learned that our participation as an African American community in asking important questions of healthcare research and participating in that research is far too low, and it remains so today. So part of the work that we need to do is to increase our interest and participation in clinical research. So those were the lessons I learned from those 3 experiences in my own life, with my own family. Of course, there were many more with patients, as a psychiatrist, as an administrator, as a researcher. But I want to switch to another question I asked earlier, and that was whether or not we should focus on COVID as a way of thinking about health disparities, as a way of learning things that would help us to better health. Or whether or not we should be thinking about chronic illnesses, things that we know as longstanding disparities. I think we should talk about both. I think we should think about COVID as a teaching experience about the urgency for us taking a long view. Let me explain. So we think about how COVID has affected the African American community. More infections, more serious infections that lead to hospitalizations, and more deaths. What about hospitalizations? Hospitalizations in non-Hispanic whites is about 93.5 per 100,000 people. For the African American community, 389.8 per 100,000. This disease has a serious lean on the African American community. Mortality is also much higher. If you look at the non-Hispanic white community, the mortality is 54.4 per 100,000. For the African American community, 108.9, nearly twice what it is in the white and Asian communities, which have the lowest rate of mortality from this disease. So, of course, we have to ask the question, why is that? And we don't know exactly, but there's certainly a number of studies that point to underlying diseases as risk factors for more serious infection and poorer outcomes. Let me give you an example. Hypertension increases the risk of developing acute respiratory distress syndrome. This is a serious distress syndrome, one which often leads to death in people who are affected with COVID. The increased risk, 82%. If you add diabetes, the augmented risk is 134%. So pause for a second and think about this. These are two diseases that we know disproportionately affect our community. Hypertension occurs more often and is less well controlled in our community. And diabetes, the same. The ability for us to control diabetes and to control its outcomes in African Americans has proven to be very difficult. And let me give you an example. For African American women with diabetes, they have an increased risk of developing heart failure, end-stage renal disease, and stroke. And for African American men, heart disease and end-stage renal disease. So just looking at hypertension and diabetes helps to explain some of the ways in which acute builds on chronic. Acute is made worse by chronic. So COVID, I think, shines a light on disparities and should urge us to an urgency to address these long-standing health issues in the African American community. One of the other questions that gets asked about COVID is, why more infections? This is when we can begin the conversation about social determinants of health. The definition of that has expanded. We've now begun to really understand some of the things that could potentially affect health. With COVID, for example, the number of African Americans that have jobs that are conducive to working from home, one of the ways that you can reduce exposure to COVID, is only about 20%. Many of the jobs that we have in the community are considered essential, require us to be there in person, and therefore increases our risk of exposure to COVID. In addition, in many cases, our family structures are different. And by that, I mean that we may have greater contact cross-generationally. We may have greater care cross-generationally. And we may have living experiences where multiple generations are living in the same environment. All of this increases the potential risk for being infected with COVID. If you add to that a decreased access to healthcare, either by uninsured or underinsured individuals, or by geographic access to quality healthcare, or by not having a relationship with a healthcare provider over time, all of these things can add up to reduce the ability to know through education what some of the risks are and how to avoid them, to know what the symptoms are, and to be able to access healthcare early enough to reduce the likelihood of serious disease, or to be able to get a full range of care for serious diseases should they affect you. All of these things add up to reaffirm the things that I said earlier that I had learned. First, we have an opportunity to lean in around setting up a healthcare system that is of high quality, can be accessed by all, and is culturally competent. We have the ability to improve education around health issues to establish a platform for health awareness and treatment education in improving healthy behaviors. We also have an opportunity for research on these issues so that we understand more with clarity about the problems and get greater clarity about potential solutions. And I'm going to add the last, social determinants. And I want to talk about those just a little bit more because we really broaden the definition of social determinants or environmental factors that impact health in our community. Let's take a few examples. Environmental factors. What about clean air in your house and outside of your house? What about clean water? How important is that? We know vary. What about nutritious food and access to it? How about having safe surroundings to reduce accidents? All this and more are a part of the environment that helps develop a healthy lifestyle and a healthy life. And so it's critically important for us to understand those. In addition, to think about economic factors. What is the effect of jobs, of housing, of transportation, of education, of food security? How should we think about having economic tools in the community, like banks or business opportunities to establish businesses and grow them? All of these things create an economic prosperity loop. And in that is a chance for a health prosperity loop. So our opportunities to increase the economic health of our community can help us increase the health of our community. So I've gone through a number of factors, things that have been demonstrated or that we believe could have a potential positive effect if we could change them and transform them. And I believe that we can. So what do we do now? I have been in healthcare for nearly 4 decades. And sometimes I look back and say, what have we actually been doing? Because I'm not sure that we've made the progress that I would like to see in closing gaps in health disparities and improving our march to health equity. And many people have asked me now, so what are you thinking now? And I have to say, I feel optimistic. I feel hopeful. I feel faithful that with the focus of Healthy Churches 2030, we'll be able to lift our community in health. That we'll be able to be back here in 2030 and say, we want to celebrate the many people whose lives we've changed or saved with our focus on health education, on health literacy, and health programs that help increase healthy behaviors. I believe that we'll be commending the work that we've done to advocate for transformative healthcare, that we will have increased access to high quality, culturally competent care. And I believe that we'll be praising our work in increasing our involvement in research, the research that will answer the questions that we have and help us find the solutions to greater health. I am so excited to be a part of this, and I know that you are too. Let me end by saying to each and every one of you and to your congregations, I'm wishing you a powerful health ministry and much health.